Greetings to all the attendees. In this presentation, this lecture, I'm going to talk about management of hypogonadism, osteoporosis, sarcopenia, and overall frailty in clinical practice of anti-aging and longevity and regenerative medicine. I have the standard disclaimer here. This is not a medical advice. This presentation is solely for educational and awareness purposes only. So, when we talk about regenerative medicine, anti-aging medicine, longevity medicine, our patients basically are, and our clients are every aging person, irrelevant of the nature of their business, their occupation, and irrelevant of their gender, ethnicity. They all are subject for aging. And on this screen I have some of the few recent examples of patients in European Wellness Biomedical Group clinical practice. For instance, the 60-year-old male, ex-military with partial ACL tear on the background of the knee osteoarthritis, and the injury happened due to paragliding, or a 35 obese female who has a complete ACL tear and a meniscus injury during the basketball game, a 62-year-old retired businessman with a bilateral knee pain after jogging, again with the background of the osteoarthritis, or sometimes even a much younger patients, for instance, a 39-year-old police inspector with a right supraspinatus muscle tear, which happened during the physical exercise in the gym, or a 39-year-old businessman with a bilateral rhomboid muscle syndrome after deadlifts. So the common in all these people is that they are not professional athletes, they're not sportsmen, they're just regular people like you and I, like everyone else, engaged in normal, regular daily activities. They have their jobs, they have their families, they have their occupation, but they all are trying to stay healthy. They are trying to do the regular physical activity, be engaged in a regular physical exercise, lead a healthy lifestyle, of course. Unfortunately, it is not always 100% possible, and it is not always optimal in all situations, so they acquire injuries, they acquire chronic musculoskeletal pain during jogging, because of the treadmill, because of the physical exercises. And why is that happening? Because they are aging and because they have other age-related morphological and physiological changes happening in their body. Specifically, osteopenia, osteoporosis, sarcopenia, overall frailty, and aging of the musculoskeletal system. So we're gonna look into all these parameters of health, parameters of aging, because they're very connected, and they have a common denominator that defines the outcomes in every particular case, and that common denominator is the hormonal profile of the individual. And speaking of my personal experience about in this topic, it's not only a medical experience. I'm not only a physician, but I'm also a patient. I'm my own patient, a patient of myself, because I am involved, and I have been involved for more than 3 decades in amateur sports activities, in powerlifting, bodybuilding, and martial arts. I did compete as an amateur for many years and many decades, and I have developed multiple injuries. And what you see on the screen now is me training through the right biceps tendon tear on the right, long head biceps tear, on the background of the bilateral rotator cuff injury, which have been healed and treated and healed by myself and healed eventually over a span of a few months. And I'm gonna present to you how exactly I did that. So, when we deal with an aging individual, we need to understand that to a certain degree, people, even starting from the 4th decade of age, as long as hormonal decline starts, we start developing insidious signs and features of general frailty that, of course, includes the physical frailty and the cognitive frailty and psychological frailty as well. So it involves all domains of our existence. Physical frailty, of course, plays a great role inside the general frailty, and it's very much driven by sarcopenia, the loss of the skeletal mass, lean skeletal muscle mass in the body. That, of course, will define further physical disabilities and physical frailty. So sarcopenia is a loss of the skeletal muscle mass multiplied by a poor muscle quality, because the composition of fibers and the quality of fibers throughout the age is changing as well. And frailty, on the other hand, is a combination of the fatigue, sedentary behavior, sometimes weight loss, predominantly because of the loss of the skeletal muscle mass, cognitive impairment, sociological and psychological impairment. It leads to the social isolation, and together sarcopenia and frailty define and drive physical function impairment, which is defined by the weak muscle strength, slow gait speed, poor balance, and very often, in practically all cases, this situation is complicated by chronic pain. Altogether, it causes functional decline, disability, and early disability to a different degree, and increased mortality rates. Of course, we encourage all our patients to be and to stay physically active, exercise, gym, resistance training, cardio activity, different court games, and so on and so forth. And unfortunately, all those activities are not complication-free, they are not injury-free. And practically every aging individual, whether it's a professional athlete or amateur or just a recreational athlete, they develop chronic musculoskeletal injuries throughout these activities. And on the screen, you can see the most frequent presentation and most frequent clinical scenarios that happen in both men and women in about the same percentage. And you can see the percentage of occurrence of injuries in a different anatomical areas, whether it's plantar fasciitis, Achilles tendinitis, ankle sprains, meniscal injury on the background, of course, of the chronic osteoarthritis and the cartilage degeneration, chronic lower back pain, chronic neck pain, shoulder impingement, elbow tennis, and so on and so forth. Why is all of that happening? Why, when we all know that physical exercise, physical activity, resistance training are wonderful anti-aging modalities. It's a literally anti-aging therapeutic modality, but why is it not working as we want it to work in all our patients? And why the outcomes of the physical exercise with age in the cohort of the older individuals is not working as we want it to work? Well, the explanation is on your screen, because there is a general aging of the entire organism as a biological system, and also there's a bone and muscle aging. When we talk about bone, we talk about demineralization, loss of the calcium and magnesium as the main minerals that compose the mineral component of the bone tissue. That leads to osteopenia and osteoporosis, and also age-related changes in the muscle tissue. And the drivers or the mechanisms, the pathways through which bone tissue and the muscle tissue degenerate with age are through endocrine dysregulation. Specifically, we're talking here about downregulation of the growth hormone and the growth hormone IGF-1 axis, reduction of the sex steroid production, testosterone and estrogen that play a pivotal role in the mineralization of the bone tissue, changes in the nutrition, and it's not only the elementary factors, but changes in the cellular nutrition sensors, multiplied, of course, on the dysregulation in the nutrition sensors and metabolic dysregulation that quite often happen starting from the late third and fourth decade of life. Reduction of production of growth factors, myokines and cytokines, reduction in intensity of the biomechanical signals that the physical exercise and resistance training can produce, reduction on the muscle contraction, weakening of the tendon and weakening of the anthesis, the tendino-osseous junction, the connection between the muscle, the tendon, and the point of its attachment to the bone, plus reduction or loss of the activity of the stem cells, specifically the satellite stem cells, which have the ability to regenerate muscle tissue, the reduction of the production of the osteoblasts and osteocytes, and reduction of the myocytes, while there is an increase in the activity and the production of the adipocytes, which contribute to further changes in the body recomposition towards the increased adiposity of the body and reduced lean muscle mass. So on this slide, you see a comparison. This is the MRI of the thigh, and you see a comparison in the density and the quality of the lean muscle tissue, and in this particular case is a quadriceps muscle, in a clinical setting and in the experimental setting. In the setting of the clinical trials, the quadriceps muscles, because it's one of the most massive muscle in the human body, is very often used as a diagnostic criteria to assess the level and the degree of muscle loss, sarcopenia, and the difference in the density of the muscle tissue between the 25 and the 75-year-old individual is very clear. And we also can see the changes in the quality of the bone tissue, and we see a massive fat tissue inclusions and depositions surrounding the muscle bellies. That, of course, changes the appearance of this anatomical area, but it also tremendously impacts its functionality. It's definitely that such muscle that you see on the right side is less active metabolically and can provide much less power than in the young individuals. And here is another slide. Again, on the left is an absolutely young, healthy individual. You can see very minimal inclusion of the fat tissue, high density, great quality, well-defined bellies of the lean muscle tissue. In the middle, on the middle slide, it's the same anatomical area, but in a 70-plus individual. So there's 50 years of difference between the left and the center slide. And on the right, we see a situation that is almost practically identical to the MRI picture on the left. However, this person on the right is also a very senior individual. This is a 70 plus, 75-year-old individual. And we can see that there's a huge, tremendous difference between the center slide, another 75, and the right slide, another 75 individual. And this 75 individual muscle tissue looks on the MRI almost like the 21-year-old individual. What is the difference here? Well, there's two main differences. First of all, the center slide is a MRI image of untrained aging senior adult, and the right slide, who is being untreated, and the right slide is the MRI of the muscle, lean muscle tissue in a previously physically active, an amateur recreational athlete of a 75-year-old now, but who has been treated with a holistic approach that optimizes hormonal profile and tries to targets the offset of the sarcopenia and osteopenia symptoms with age. Another slide, and this slide is the bone density scan. On the left, you can see a 77-year-old individual with a severe osteoporosis, and you can see tremendously reduced bone density in the neck of the femur on the left, on the scan of this patient. On the middle slide is the bone density of the 55-year-old individual that has some moderate signs of osteopenia, however, no pronounced osteoporosis yet. And this person is in process of being holistically treated and in process of undergoing anti-aging, longevity, regenerative medicine treatment, including but not limited to the stem cell treatment and the hormonal optimization. While on the right slide, we see again the bone density scan and absolutely normal bone density of the left femur. And this person is also in the 7th decade of life. This person is almost 70 years old. It's a 77-year-old individual without any signs of osteoporosis or osteopenia at all. What is the difference between these three people? When the individual on the right, this case, have been treated consistently for hormonal optimization and has been treated in terms of the longevity and anti-aging regenerative medicine protocols in European wellness facilities for quite a significant amount of time, and you see that there's no signs of osteoporosis and even osteopenia on the MRI scan. Let's look at this slide. The body composition analysis that takes into consideration, that assess not only the total body weight, the BMI, but also the dry lean mass, body fat mass, skeletal muscle mass, and the fat-free mass, as well as together with the hydration and the visceral adiposity. And on the left side, we see the typical C kind of a pattern. Increased total body weight, reduced skeletal muscle mass with a tremendously increased over body fat mass, increased percentage of body mass. And on the right, we see a typical D pattern, which means skeletal muscle mass is significantly over increased, way more than the total body weight and way more than the body fat mass. So it creates that as similar to the alphabet or the letter D pattern. Person on the left is obese with a sarcopenia. Person on the right is lean with very little, less than 50%, at 32% visceral fat, which is more than half below the so-called acceptable normal range, and borderline lower normal range or below the lowest normal range of the body fat mass. However, almost plus 59%, 54% of the skeletal muscle mass. And this person is almost 20 years older than the individual on the left. Again, the main difference between these two cases is the one on the left has not been treated holistically for anti-aging and longevity, has not been hormonally optimized, has not been metabolically optimized, while the person on the right slide is a consistent patient of the anti-aging longevity medicine clinic, which has been treated persistently for years, metabolically and optimized hormonally. Hence the changes in the big difference in the body composition, amount of the skeletal muscle mass, percentage of the body fat mass, and significant differences in the visceral fat percentage. Why is that happening? Specifically in males, because of the age-related testosterone decline that starts after about the age of 30-32 years old, that has 1 to 1.5% of the total testosterone level yearly decline, plus 1.5 to 3% of a yearly decline over free or bioavailable testosterone range. We consider the asymptomatic or the optimal range of total testosterone above 25 or above 25 nanomole per liter or 800 nanogram per deciliter. So in nanomole per liter, the ratio between 25 to 31, and from 800 to 1,100 nanogram per deciliter is a sort of asymptomatic normal sweet spot of the testosterone level. What happens when the hypogonadism occurs, when the testosterone levels start reducing? Well, we develop the condition which we call the hypogonadism, and it's very closely related and associated with the metabolic syndrome. Specifically, the low testosterone syndrome is associated with insulin resistance, obesity, hence the dyslipidemia, type 2 diabetes, hypertension, non-alcoholic fatty liver disease, almost fourfold increase in occurrence of the coronary artery disease, coronary events, and tremendous increase in pro-inflammatory cytokines and adipose cytokines. So what are the further additional challenges in managing aging individuals and their chronic skeletal muscle injuries and musculoskeletal pain? Well, it's overall reduced regenerative capacity. It's a slower healing, slower recovery. It's reduced to a different degree flexibility and mobility of the joints, osteopenia and osteoporosis at a different degree, age-related changes in ligaments, tendons, thinning of the cartilage, sometimes that always is happening even with or without osteoarthritis, muscle atrophy, and reduced muscle regeneration potential. Slower healing, why is it happening? Well, due to multiple factors. First of all, reduction of the endogenous production of the growth factors that slows down the healing on the cellular, subcellular levels. Reduction of the output of the satellite stem cells, and the satellite stem cells are the small size stem cells that are involved in a rapid response to any sort of the injury to the musculoskeletal apparatus, the small tendons, or the microscopic injuries to the myofibrils, the injuries to the tendons, usually are healed by the satellite stem cells that act like little patches that literally patch that area of the injury, of the cellular injury will patch with the cells. It causes slower wound healing, slower healing and recovery of the injured muscle, tendons, and ligaments. That overall causes and creates the higher complication risk in all these patients. Plus, we need to understand that we're dealing with aging people who are aging systemically, so they have underlying vascular neurotrophic deficit, insulin resistance, and chronic low-grade inflammation, which are the hallmarks of the aging. Plus underlying osteoarthritis that may involve one, two, or multiple joints of a different degree in the body, and sarcopenia. Speaking about the increased risk of complications and increased risks of the re-injury when the injury is not healed completely, partially healed injury has been reactivated, refreshen regularly, and that ends up with that chronically non-healing injuries. Further contributes to frailty. Very much is caused and exacerbated by the nutritional deficit, sometimes because of the medications, side effects of the medicinal medications intake, and different psychological factors, because once individual develops, acquires an injury, there will always be a stigma that will sort of prevent them from training further or exercising further or going all out, you know, so it will limit their activity also psychologically. And that creates a need for the personalized treatment protocols, which are absolutely a must in the setting of the regenerative anti-aging facility. The treatment plan, treatment protocol for every individual has to be individually tailored with understanding and taking into consideration the uniqueness of injury and specific individual needs and limitation. It must be focused on the prevention of further injuries and the re-injury. And if the treatment modality is involved, preferably it has to be a minimally invasive technique which will not further debilitate patient and which will have the very minimal downtime and will not and will prevent them from sort of withdrawing from the physical activity. So this entire situation is additionally complicated by a fact that a large number of aging individuals globally in the world are affected by the osteoarthritis. For the past 30 years, we have over 100%. Since 1990, is a 113% increase in the prevalence of the osteoarthritis globally, and such additional underlying conditions such as obesity, metabolic syndrome, hormonal disorder, sarcopenia make prevalence of osteoarthritis even worse. On the screen, you can see the breakdown of the which anatomical areas are mostly predominantly affected by the osteoarthritis and the symptoms of the osteoarthritis that are almost persistently present morning till night in all the patients who have this condition. Conventional treatment and conventional management protocols, unfortunately, are unsatisfactory. It's usually either some assistive techniques, braces, non-steroidal anti-inflammatory medications, painkillers, physiotherapy, various supplements or medicinal products like the corticosteroids, hyaluronic acid, glucosamine glycans, or the surgical procedures such as the joint replacement therapy, well, they are not definitive, most of them. They are not inconvenience-free. Very often they cause a downtime. None of them provides a definitive 100% lifelong solution to this problem. On top of that, there's a number of age-related factors that make conventional treatment strategies even more ineffective. Again, reduced muscle mass, increased fat mass. It's a body composition changes that alters joint loading. It just adds on to the gravity and creates a higher burden, a heavier burden on the joints. In the same time, it has biochemical systemic changes such as the increased adipokine and cytokine production that results in a low-grade systemic inflammation. Changes in the extracellular matrix in the musculoskeletal system, accumulation of the advanced glycation end products, reduced amount and size and quality of the aggrecan and other proteins that contribute to the strength of the extracellular matrix, reduced hydration overall, that tremendously happening with age, and increased collagen cleavage, together with the reduction of the synthesis of the collagen. It all makes musculoskeletal system more susceptible to degeneration, osteopenia and osteoporosis, loss of the lean muscle mass, and also loss of the quality of the lean muscle mass, and changes in the composition of different types of the fibers and also the minerals, and overall contractile capacity of the skeletal muscles. And all of that is associated with overall overwhelming catabolic processes and cell death on the background of the reduced autophagy, oxidative stress, and mitochondrial dysfunction that is happening in all tissues, including the cartilage. And of course, all other marks or hallmarks of general chronic aging, which we know and we talk about in every lecture, not gonna stop on this in details. So the changes that are happening in the cartilage, they do involve both the cellular component of the cartilage, the chondrocytes, reduction of the quality and production and maturation of the young chondrocytes, and also degradation of the extracellular matrix, very well illustrated on the slide, plus the changes in the physiology and the biochemistry of the cartilage tissue, specifically senescent-associated secretory phenotype, kind of cells that become predominant in the cartilage cells, together with the mitochondrial dysfunction, oxidative stress, reduction of the AMPK gene activity, reduced autophagy, altered cell signaling, and age-related changes in extracellular matrix, together make worse the catabolic and senescent changes in the cartilage and drive the pro-inflammatory component of the osteoarthritis that in the end causes joint failure. Unfortunately, the problem doesn't end here, because the degeneration of the joint always spreads on the surrounding tissues, and that phenomenon is known as the inflammatory periarticular lesion syndrome, aka joint failure, that involves atrophy of the muscles that are surrounding and covering the joint, plus the inflammation, sometimes even the active inflammation, productive inflammation with exudation of the various compartments and synovial sheath membrane inflammation that surrounds the joint together with the cartilage breakdown, bone remodeling, sclerosis, synovial hypertrophy, and the meniscal damage and the muscle atrophy. How to approach it, how to treat it, and we have been discussing this topic in some of our publications. Some of them you see on the screen, I quoted there. So a treatment involves systemic approach, so it's a systemic treatment and a local treatment. Systemic treatment overall would mean activation of the anabolic processes, activation of the process of the repair, tissue rebuild and regeneration. That happens through the activation of the mTOR gene. That target is achieved through the stem cell therapy and hormonal optimization. Plus the local treatment. The local treatment usually targets local inflammation. It's a reduction of the inflammation in the specific anatomical areas, plus promotion of the healing. And that is achieved by the peptide therapy and the exosomes. Systemic treatment. And one of its components is, or the pathways, is through the stem cell therapy. In our practice, we predominantly use progenitor or precursor stem cell, which are the stem cells that are more or less committed on their differentiation pathway. These are not multipotent cells. These are rather unipotent progenitor cells that are determined to a specific pathway of a cellular differentiation. But in the same time, these cells also possess all the properties and the qualities of the mesenchymal stromal cells, such as reduction of the systemic chronic low-grade inflammation and immunomodulation. Apart from that, progenitor stem cells have the capacity to perform homing, direct homing into the tissue to provide tissue regeneration, and also through the systemic migration and homing to the targeted organs. It can improve the organ function in practically all organs and systems in our body. And the third additional pathway of its mechanism of action is mTOR activation that will promote tissue regeneration. A second component in the systemic treatment is hormonal optimization. And here we mean specifically the testosterone axis, the sex hormones, and stimulation of the hypothalamus pituitary adrenal gonadal axis and the endogenous synthesis of testosterone, and human growth hormone IGF-1 axis that also acts as a hypoplastic and regenerative hypertrophy stimulating and regeneration stimulating pathway. We have done some work previously on this, and you can see the slide, you can see the photograph with the article about the hormonal revitalization therapy from the perspective of biological regenerative medicine, and the slides which illustrate the changes in the total testosterone level down here on the left from the day 0 throughout 1 year in the treated cohort of the males, and also the middle and the right chart down here on your slide. You can see the changes in the estradiol and the FSH level in the female individuals with premature menopause that were treated with our protocols of hormonal optimization quite successfully, and we see that practically there's a 100% response rate in all the patients. And the second line of therapeutical targeting is through the human growth hormone replacement therapies, and we've been talking about it in previous lectures and presentations also multiple times. I'm not going to stop on it, but I'm just going to mention that it involves the growth hormone replacement therapy. It's a standard stimulatory treatment protocol. We have increased the successful outcomes of the hormonal optimization from 70% using the standard approach to 100% in our case. A second benefit was that the yield of the total testosterone level was more than 4 or 5 times higher than with the standard approach. We managed to increase the total testosterone level for more than 200 nanogram per deciliter, or more than 7 nanomole per liter, compared to the standard approach on the average. And the third benefit is a significantly more lasting outcomes. The benefits are way more lasting. It's 1 year plateau of total testosterone level versus only a 2-3 months plateau which we observe after the standard therapy, and 1 year plateau of a testosterone level after our modified hormone optimization protocols. Local injection techniques include intra-articular injections, peri-articular injections, perineural infiltration, and injections in the osteotendinous junction, or also known as the anthesis injections. This type of minimally invasive techniques can be done as ultrasound guided, but also using the landmark techniques. And the main features of landmark techniques and ultrasound guided techniques you can see on your screen. The idea is to identify the shortest route from the surface of the body, from the skin to the area that is targeted by treatment. Pretty much a holistic effect for the entire joint. And a second domain would have been exosomes. So if you compare exosomes to MSCs, which they are usually procured from, they are absolutely no special requirements for their storage. They can be stored for a long time, easily available, tremendously cheaper cost compared to the stem cells, just a fraction of the price that the stem cells cost. They are suitable for frequent application, frequent administration, even every other day, for instance. And exosomes easily pass through different membranes in the organism, even the blood-brain barrier, much higher permeability than it is permeable for the MSCs. Altogether, exosomes produce anti-inflammatory effect, strong regenerative effect. It stimulates cellular renewal, stimulates collagen synthesis. It has the immunomodulatory, neuroprotective, anti-catabolic, and anti-apoptosis properties. The local injection tactics involves the identification of the specific landmarks, imaging study, whether it's MRI or ultrasound or X-ray, whatever is necessary and sufficient for adequate assessment of the problem that every person has, plus the clinical and physical examination, because very often chronic pain is defined or caused by the chronic inflammation in the nerves, with or without nerve impingement in that particular area. That's why the intra-articular and peri-articular injections may not be sufficient for a complete reduction or elimination of the symptoms. So on this screen you can see illustration of such holistic approach when for one of the patients. This is a professional athlete who has a severe osteoarthritis of the right humerus bone, together with the severe rotator cuff syndrome, treated systemically by the stem cells and exosomes, plus the surgery. The patient actually went through the arthroscopy, and in a post-operative period, 8 weeks of systemic and local treatment with biologicals, with stem cells and exosomes. And you see the infiltration with exosomes in the early post-operative period of the affected area. Another patient, the ACL test with a meniscus injury on the background of the advanced osteoarthritis. Both knees have been treated with intra-articular and peri-articular administration, and now you can see ongoing perineural infiltration therapy with placental growth factors, nanomized placental growth factors, and exosomes. You see that specific areas where we put the injection, where we place the needle, have been already identified, and the needles have been inserted there, and just I'm changing the syringe with different biological agents to infiltrate those anatomical areas around the knee joint. It's another case of a very combined injury of knee joint and ankles, with the meniscus tear and with the ACL tear and with chronic osteoarthritis. And you can see the actual treatment protocol. 3 sessions with at least 2 weeks in between, using the potentiated local anesthesia, potentiated with a short-acting corticosteroids. It's optional, with the adding of the sodium bicarbonate to make the microenvironment in the tissue alkaline, less acidic, so that will further promote healing and will reduce the inflammation and pain. Nanomized peptides of the synovia, nanomized peptides of placenta, and Dmytro organelles placenta, 4 vials, so in total 10 milliliters, are administered periarticularly. On the second session, again, after the local anesthesia with the alkalizer and potentiation, intra-articular administration up to 10 IUs of the ultra-human growth hormone with the BPC 157, around 500 to 600 microgram intra and or periarticular, and nanopeptides and Dmytro organelles placenta and cartilage, up to 8 to 10 vials on distributed equally periarticularly around the treated joints. And the third treatment session, again, local anesthetic with the alkalizer, and this time we use exosomes, intra-articular, just 5 milliliters per joint, and periarticular infiltration and perineural infiltration with nanomized and mitochondrial peptides of placenta and cartilage, again roughly around 8 to 10 vials for the whole treatment. So as a summary, you can say that constant physical activity is crucial for aging individuals, and prevalence of overuse, injuries and joint degeneration and delayed tissue repair increases, and conventional therapies fall short in promoting long-term recovery and definitive treatment and tissue regeneration. Hence, the biological mechanisms of stem cells is enhancing tissue repair through anti-inflammatory, immunomodulatory and regenerative pathways, are very much used in the contemporary anti-aging longevity regenerative medicine. We do advocate and promote the concurrent use of various biological therapeutic agents that enhance and accelerate healing, reduce inflammation, and improve musculoskeletal function, be that progenitor cells, peptides, organ-specific peptides, placental growth factors, growth hormone, its secretagogues, and exosomes. And the proposed therapeutic strategies are safer and looks like they are more effective than most of the conventional approaches, such as corticosteroids, for instance, and have a superior efficacy profile and are suitable for frequent use in a wide category of patients. I would encourage to do some further reading, some of the books and articles and write-ups on this topic, on the topic of the minimally invasive techniques and hormonal optimization that our group of researchers have been working in the past years. Please visit our websites for more information and to see the actual protocols and the testimonials and the write-ups and literature and books and articles that have been developed by European Wellness Biomedical. Thank you very much for your attention, and remember that you don't have to get old with age.